Welcome back to Neuroclarity, the podcast where we break down complex neuro cases into clear, memorable stories. I am Onowori Victor, a neurology resident applicant, and today's episode features two fascinating cases adapted from Ching Cheng's comprehensive review of clinical neurology. We've done questions 1 to 13 of chapter 2 of this Ching Cheng's comprehensive review, and right now we'll be doing questions 14 and 15. So let us dive into today's case. Question 13. We have a 59-year-old woman with a history of atrial fibrillation and hypertension who presents with right hemiparesis affecting mainly the face and arm. Her eyes are deviated to the left. She seems to be able to understand and follow commands, however, cannot verbalize and appears frustrated when asked questions because she cannot answer. Where is the most likely location of the vascular occlusion? Options A, trunk of the left MCA before the bifurcation. Options B, lenticulostriate branches of the left MCA. Option C, superior division of the left MCA. Options D, inferior division of the left MCA. Options E, penetrating branches at the level of the pons. Okay, so let's do a little breakdown of this. We are looking at the patient with weakness affecting mostly the face and arm, not so much the leg. Her eyes are deviated to the left and she's struggling to speak, although she can clearly understand what's going on. Now, this classic presentation points towards Broca's aphasia and hints at an infarct of the superior division of the left MCA, hitting the dominant hemisphere's inferior frontal gyrus. Let's unpack this a little further. Why the face and arm weakness? Now, the lateral surface of the cerebral hemisphere, particularly the motor areas for the face and arm, is supplied by the MCA, the middle cerebral artery. And ischemia here leads to this selective pattern of weakness. Why the eye deviation? Now, with damage to the left frontal eye fields, the right frontal eye fields are unopposed, pulling the eye towards the left, that is the side of the stroke. Can we remember what the frontal eye field's Brodmann's area is? If you said Brodmann's area 8, you are right. Brodmann's area 8. Now, why Broca's aphasia? Remember that Broca's aphasia is an expressive aphasia and the patient can understand but cannot produce speech. It is often extremely frustrating because they know exactly what to say but they cannot just express it. And the lesion is in the inferior frontal gyrus supplied by the superior division of the MCA. Now, a quick one. Broca's area is area what? If you said area 44 and 45, you are absolutely correct. Now let's make a contrast with other MCA syndromes. If the infarct were in the inferior division of the MCA instead, we would expect something we call the Wernicke's aphasia, which is the fluent but nonsensical speech with poor comprehension. Basically, they say what is called the word salad. If the entire MCA trunk were occluded, we would see global aphasia involving both comprehension and speech production, plus hemiplegia affecting the face, arm, and leg due to deep ischemia involving the lenticulostriate arteries. Now, what if we had an isolated infarct in the lenticulostriate arteries? Well, like our previous episode, this would cause pure motor hemiparesis without any cortical signs like aphasia. Now, what if it was important stroke? Well, we would expect motor symptoms but not Broca's aphasia, and that's because the pons does not manage language. So, let's take a recap. Face and arm weakness, eye deviation, and Broca's aphasia, think superior division of the left MCA infarct. Understanding preserved but speech impaired, think lesion in the dominant inferior frontal gyrus. Global aphasia with hemiplegia, think MCA trunk occlusion. Pure motor hemiparesis without aphasia, think lacunar stroke in the lenticulostriate territories. Now, let's look at the options. So, from what we've said, our option will be the superior division of the left MCA, option C. Okay, so on to our next question, question 15. A 51-year-old man with hypertension and diabetes presents with left leg weakness associated with urinary incontinence. This patient was known to have a normal circle of Willis based on a previous MRA performed for other reasons. Here is the most likely vascular occlusion. A. Right anterior cerebral artery, proximal to the origin of anterior communicating artery. B. Right anterior cerebral artery, distal to the origin of the anterior communicating artery. C. Anterior communicating artery. D. Superior division of the right middle cerebral artery. E. Inferior division of the right MCA. Okay, so first things first, let's have this clear. This case features a patient with ischemia in the territory of the right anterior cerebral artery. Now, here's an interesting fact. Because the two anterior cerebral arteries communicate through the anterior communicating artery, an occlusion that occurs just before that communication point, that is proximal to the anterior communicating artery, might not cause any symptoms, assuming this patient has a well-formed circle of Willis. And that is critical. When do we actually see symptoms? We see symptoms if this occlusion happens just distal to the anterior communicating artery, that is further downstream, cutting off blood supply to specific territories that are supplied by the right anterior cerebral artery. What are the clinical features of a distal anterior cerebral artery stroke? When there's distal anterior cerebral artery infarct, we have some clinical signs, and they include one, contralateral sensorimotor deficits that mainly affect the lower extremities but spares the arm and the face. We also have urinary incontinence, and this is due to damage to the medial micturition center in the paracentral lobe. Sometimes you may see eye deviation towards the side of the lesion and paratonic rigidity. What is paratonic rigidity? That refers to an increased resistance to passive movement. Now, do you know what is missing? Yes, there are no major arm or face deficits, and this can help you to distinguish an anterior cerebral artery stroke from a middle cerebral artery stroke. Key differentiators include the following. 1. Anterior communicating artery occlusion alone typically does not produce symptoms if the circle of Willis is complete and intact. 2. MCA territory infarct causes problems in the face and arm but spares the legs. 3. Anterior communicating artery infarct focus their damage on the contralateral leg and possibly affect bladder control. So, let's summarize. Lower limb weakness and sensory loss, possibly with urinary incontinence, think distal anterior cerebral artery stroke. Face and arm involvement without leg symptoms, think middle cerebral artery territory stroke. No symptoms despite anterior cerebral artery occlusion, it's probably proximal before the anterior communicating artery. So, back to our question. We say the answer here is B, which is right cerebral artery distal to the origin of the anterior communicating artery. Thanks for tuning into this episode of NeuroClarity, where we break down neuro cases one clear step at a time. This case, like many of our discussions, is adapted from Chink and Cheng's comprehensive review of clinical neurology. Stay tuned for more cases, and remember, the key to mastering neurology is to think anatomically. Until next time, stay curious and stay clear.